Um, and yeah, I'm so excited to be here. Thank you all for having me. Um, uh, as Dr. Salgado said, I just finished up my PhD in health economic and outcomes research at the School of Pharmacy in University of Washington. Um, but unlike many of you, my background is not in pharmacy. My background is more in public health. And so I'm excited to share this research with all of you because it nicely combines some of those broader community health implications with all the important work that you all do as pharmacists. And I'm excited to see that one of my dissertation committee members, Dr. Parth Shah, is with us today too. So morning, Parth, and feel free to jump in anytime with comments or questions. It's good to see you. Okay, I'm going to share my screen here and then we can get started. As Sydney said, she's going to share the CME credit information at the end here. So I'll put it up again if needed. Alrighty. So the topic I'm going to talk about today is two research aims for my dissertation, where I'll be looking at the importance of access to pharmacies and pharmacy services, and specifically using adult vaccination as a case study. So I'll leave a bunch of time for questions at the end, hopefully. But if anything is unclear, please feel free to jump in at any time. I'm first going to give some context for this research and then dive right into each of the two studies I'll share today. So first, I'm going to look at pharmacy deserts, and then second, I'll examine whether pharmacy deserts are related to shingles vaccination uptake. And then, like I said, I'll leave some time at the end for some more questions, hopefully. So here we go. First, some background. Like I said, I myself am not a pharmacist by training, so I've learned a lot over the past several years during my PhD program about all the vital services that pharmacies provide. So first, of course, pharmacists dispense many important medications for acute and chronic illnesses. And this is really important because nearly 7 of every 10 adults between 40 and 80 years old take at least one prescription drug, and roughly 1 in 5 adults take 5 or more prescription drugs. So that's a lot of people needing a lot of medications from pharmacists. But beyond dispensing medications, pharmacists also provide a long list of patient services, including counseling patients about managing multiple medications, managing side effects and adherence. They provide testing and screening for a number of things, reproductive health services, tobacco cessation, a long list of really important patient health services, as well as dispensing medications. And as we all saw during the COVID-19 response, pharmacies were vital infrastructure for pandemic response and for pandemic preparedness as well. During COVID, they provided they provided testing and screening as well as vaccinations, of course, and was also a place where many people were buying hand sanitizer, masks, and other basic supplies. And pharmacists were key during the 2009 H1N1 swine flu response as well. And underpinning all of this is health equity and having equitable access to these health services. We know that low-income families have better access to pharmacies than to primary care providers. And some low-income groups have increased risk for certain chronic illnesses like diabetes. So access to pharmacies is especially important for individuals in these groups. But the bottom line is pharmacies provide vital healthcare to a lot of people, and having access to them is important. One of these many important services, which I'll be talking about more today, is vaccinations. And adult vaccinations are below targets in the US for almost every single vaccine on the ACIP adult schedule. This includes flu, HPV, PCV, tetanus booster, and now recently COVID-19 and RSV vaccines have been added to the schedule as well. And vaccines provide protection from these illnesses and are also some of the safest and most cost-effective health interventions that we have in our public health arsenal. Yet these rates are consistently low, and for many are actually dropping year over year. And to give a sense of the burden on top of the health burden, A 2015 study estimated that in a single year, the economic burden attributed to and under-vaccinated adults was $8.3 billion just in a single year from inpatient and outpatient treatment costs. So closing this gap is really important for a number of reasons. And pharmacists are really well positioned to help address this gap. Because while primary care providers are the main provider of childhood immunizations, pharmacies provide a lot of adults with their vaccinations. They provide over 90% of shingles vaccinations, as of a few years ago, provide more shingles or provide more seasonal flu vaccines than primary care providers do. And they have provided the majority of COVID-19 vaccines as well. Pharmacists and pharmacies are also highly trusted by their communities, according to qualitative research, a few qualitative research studies. They have convenient hours and appointment scheduling and many more geographically dispersed locations than primary care providers. And pharmacists are, lastly, of course, trained to provide vaccines, and it's within their scope of practice to administer vaccines and in many cases prescribe certain adult vaccines in all 50 states. And the example I'm going to be talking through today is shingles or herpes zoster as a case study example for the role of pharmacists as vaccinators. For just briefly, for those who aren't familiar, shingles is, it often causes a painful rash lasting a few weeks, although up to a third of shingles patients can develop an intense pain that lasts months or years. For adults who live to age 85, their lifetime risk of developing shingles is about 50%, and there are about 1 million cases diagnosed in the US each year. And the current vaccine that we have is called Shingrix, and it's over 90% effective in preventing shingles, and it's given in 2 doses about 2 to 6 months apart. And like I said, pharmacists provide over 90% of shingles vaccines. Briefly, knowledge check here. Folks can please respond in the chat. Our first question of a few that I'll have throughout here. And this question asks, why are pharmacists well suited to improve adult vaccination rates? And I'll just give you a minute to read it before moving on. Folks can either unmute or drop your answer in the chat. All right. Good. I'm seeing mostly response D coming in, and that is correct. So good that everyone is paying attention so far. I appreciate it. And so with that, I'm going to dive into the first study, given that background context. And the term I'm going to be talking a lot about today, which many of you have probably heard, is pharmacy deserts. And this term has been around for over a decade, but became really, really popular in the context of the COVID-19 response. It became a bit buzzwordy. It was used in a number of academic papers as well as lay press and other news outlets. And it does have a specific definition that I'm going to review in the context of this research. So the definition that I'm going to be using for this has 2 parts. First is that a pharmacy desert is a neighborhood that has low access to pharmacies. And this is defined as that more than a third of the population lives farther than a certain distance from a pharmacy. And this distance varies depending on whether that area is urban, suburban, or rural. And the unit of area that I'm using for my research here is a census tract, which is much smaller than a county and comprises often several blocks. And I'll be showing a map later so you can get a sense of that. But that's what I'm using as the unit of geography for neighborhood. So the first part of the definition is this neighborhood has low access to pharmacies. And the second part is that this neighborhood also has to have low access to resources, which we define by using a few variables about proportion of population living below the federal poverty line and median income. And this definition is derived from 2 things. It's based on the expansive literature on food deserts, which uses this same 2-part structure for its definition. And then these radii for acceptable distances to a pharmacy come from the access requirements in Medicare Part D minimum pharmacy benefits. So that's the definition we're working from. And just to visualize it in a different way here, If we pretend that each of these squares is a neighborhood, we see that, and I've outlined here the two layers of the definition. All the ones in yellow are what I'm going to call low access tracts. So that's a tract that meets the first half of the definition, and that they have low access to a pharmacy, regardless of their income status. And then in orange, I'll layer on tracts that meet that first half. They're low pharmacy access tracts, and they are a low income neighborhood. So that meets the second half of the definition. So keep this in mind. I'm going to come back to it in both studies that I'll review today. I'm, of course, not the first person to study pharmacy deserts. The term was first coined by Dima Kitu, who's now at USC, in 2014 in her study of pharmacy deserts in the Chicago area. And since then, there have been a number of studies at the local level in a number of states and counties throughout the US, including LA County, Chicago, New York City, Shelby County, Tennessee, a number of other places. And they've also been described at the county level for rural counties throughout the US. And some of these studies have also begun to describe characteristics of populations living in pharmacy deserts, and some related patterns, such as we know that closures are increasing over time, and that pharmacy closures are actually associated with worse medication adherence. This was another study by Dima Kitu in LA that showed that when the neighborhood pharmacy closed, the patients who had previously been served by that pharmacy had a clinically significant decline in their cardiovascular medication adherence. And we also know that these studies are piecing together evidence that living in a pharmacy desert is associated with several social determinants of health. And I'm going to talk more about that as well. There have been a couple other studies in the past year that I have not updated on this slide. But long story short, at the time of my research, there was no comprehensive map at the neighborhood or census tract level of pharmacy desert locations in the US using the definition I just described. So that was the first objective of my research, is to define a nationwide map of pharmacy deserts using a consistent definition, and characterize the populations that live in them and the pharmacies that serve them. And to do this, I used data from the National Council for Prescription Drug Programs about pharmacy locations and some of their characteristics. And then I used data from a few different sources from the Census Bureau, including the 2020 decennial census for population counts and land area, and the 2021 5-year American Community Survey for various population characteristics. So I won't go through all of these in the interest of time, but essentially I use those data sources to categorize each tract based on their pharmacy access status, and then and then align those with population characteristics and social determinants of health to be able to describe the population. So ultimately, my data set for analysis included over 83,000 census tracts, and there are 84,000 in the US. So essentially, I'm looking at every census tract in the US minus those that have a population of 0. There are about 1,000 of those. And taking that data set, I had all the variables in my data sources and was able to aggregate those into the key measures, like proportion of population with median income less than a certain threshold, and then proportion of population within a certain radius of a pharmacy. And this is what you'll recognize these as the components of the pharmacy desert definition. And so without further ado, what did I find? Nationally, I found that about 16 million people, or about 4.7% of all people in the US, live in a neighborhood classified as a pharmacy desert. And looking at the statewide view, we saw that the states with the largest number of people living in pharmacy deserts were California, Texas, and Florida. And those are the 3 most populous states, so that wasn't particularly surprising. But the states with the highest proportion of population in pharmacy deserts were New Mexico, Alaska, and Arizona. And I checked in Virginia is actually, which I know is where many of you are located right now, was dead middle. Virginia was number 23, if you rank states by proportion of population in pharmacy deserts, Virginia was number 23 with 4.9% of Virginia's population living in pharmacy deserts. But the goal of my map was to look at the local level patterns. And so on the next slide, I'm about to show a map of that view. It is a little busy, so I'm going to just go step by step. But this is what the census tract view of pharmacy access looks like. And on this view, you get a better sense of the rural census tracts because they're a bit bigger. I will zoom in a sec on an urban area, but just to orient you, the red census tracts are ones that were pharmacy deserts, and yellow are those ones that I mentioned that were low access tracts, but didn't meet the low income component of the definition. And then gray is not a pharmacy desert. A few patterns we noticed is these pharmacy deserts were most often in urban or rural locations rather than suburban. And to give a sense of magnitude, if the low income component of the definition was not accounted for, then our numbers increased to 34 million adults, or 13.2% of adults in the US are living in areas with low access to pharmacies. And this is zoomed in on the Seattle metro area where I live. This map is also available in an interactive version online. So if you're interested, you can zoom in on your neighborhood and see what the map looks like for your area. But some things that to recognize at a high level in Seattle is that the pharmacy deserts are mostly located in central and south Seattle, which, if you're familiar with the city, is also the areas of the city that are low income and are associated with a number of other social determinants of health. And we did examine this quantitatively throughout the whole country, and confirmed that finding, where we saw that communities that are pharmacy deserts are associated with a larger proportion of many population level social determinants of health. So in the interest of time, I won't go through all of these, but a couple to call out is that pharmacy desert tracts had a higher proportion of people with no health insurance and a higher proportion of people with lower self-reported English speaking ability. And these further, the pharmacy access was not distributed evenly by race ethnicity. For example, the proportion of people who are American Indian Alaska Native was 7 times higher, or in pharmacy deserts, there are 7 times more people who identify as American Indian Alaska Native as compared to non-pharmacy deserts. We also looked at some characteristics of pharmacies serving those pharmacy desert communities. And we found that pharmacies serving pharmacy deserts were more often independently owned as compared to those not serving pharmacy deserts. But the services that they offer are more or less the same. There's a slight difference in how often walk-in clinics are available, and that they were actually more often available in pharmacies located in pharmacy deserts. But overall, the services were fairly similar across the 2 types of neighborhoods. All right, before I get into a discussion about what all that means, we got another knowledge check here. What are some population characteristics associated with pharmacy deserts? Another softball, but feel free to throw it in the chat. Thank you, Cindy. All right. Okay, I'm seeing more answers coming in, and again, everyone got it right. It is D, all of the above. There are many social determinants of health associated with, at the population level, with a neighborhood being a pharmacy desert. And before I go into the discussion, I did want to call out a few limitations of this research that are really important to consider. There have been some major pharmacy closures since we conducted this research. The 3 largest chains, including CVS, Walgreens, and Rite Aid, have announced plans to close 1,500 stores nationwide. And in Seattle, we see that with Rite Aid having acquired the Bartell's pharmacy chain, and many of those have been closing locally. Other research also shows that these closures are more likely to happen to independent pharmacies and to pharmacies in low-income urban and rural areas. So if we were to redo this map in a couple of years from now, there would likely be a lot more red tracks. And this map also assumes that anyone can go to any pharmacy, but health insurance, of course, means that that is not the case. And this looks different for each person depending on your health insurance plan. For example, rural pharmacies in Washington are less likely to accept Medicaid. So if you live in the rural part of our state here, this map likely looks very different for you. And this definition, like I said, it's rooted in some existing definitions and CMS requirements of minimum pharmacy benefits, but there's little empirical evidence justifying what an acceptable threshold of pharmacy distance is, whether it's whether it's appropriate to have a 1 mile or a 10-mile distance remains to be studied empirically. And there's some interesting studies coming out about that, but there remains to be a consensus about what those thresholds should be. And a couple others that I'll speed through here in the interest of time is I'm looking at population level, not individual level data, and there's many geographic calculation limitations. Like I didn't use road travel distance or travel time via driving versus public transit. I just looked at linear distance. And there are many other factors that feed into what having good access means beyond just geographic accessibility. But limitations notwithstanding, there are several important implications of these findings, including some implications for patient health, which is that broadly, many adults in the US don't have good access to pharmacies. And this lack of access, one, signals important barriers in routine healthcare. I mentioned that it can have a demonstrated effect on medication adherence. It also weakens emergency preparedness infrastructure and raises health equity concerns. There was an interesting study in JAMA Network Open last year that showed evidence of an association between pharmacy locations today and historic redlining patterns, which raises concerns about leaving a legacy of structural biases and widening health disparities if these patterns are not addressed proactively. There's also implications for policy in that state and federal policies can halt the growth of pharmacy deserts and address this access issue by preventing closures of pharmacies, especially in underserved areas. And there's a number of policy mechanisms that they can pull on to do this. Provider status is a popular one that's been discussed to bolster pharmacy revenue. PBM regulation is also discussed a lot to ease financial pressure on pharmacies. There could be financial incentives for pharmacists practicing in underserved areas, and a number of other factors. Pharmacies can also leverage new technology and care models to reach patients, and some of these were piloted, especially by rural areas during COVID, including telepharmacy and mobile clinics. But a big underpin of all this is the staff shortages being felt in pharmacies around the country need to be addressed as well. But ultimately, any policy or program that tries to reach patients through pharmacies will likely have a more minimal effect in pharmacy deserts because those patients can't access those interventions in the same way potentially. And lastly, some implications for research. Beyond addressing these studies' limitations, future studies can extend this work by looking at the relationship between health professional shortage areas and pharmacy deserts. Health professional shortage areas are for primary care physicians, mental health, and dental health, but their overlap with pharmacy deserts is not clear. And I mentioned that a consensus is needed in the field on a definition of low access, including whether that income component should be part of the definition and what an appropriate access distance radius is. So there are implications for patient health policy and research from this pharmacy desert work. Okay, our third knowledge check: how might lack of access to a pharmacy impact patient health? I'll give you guys a sec to read this here too. Okay, do I see any answers coming in the chat? All right, I'm seeing a lot of answer A. Patients can face additional barriers to accessing important routine medications. And that is indeed correct. You guys are still awake and not just answering D. That's great. Okay. With that, going into part 2, pharmacy deserts and vaccination. And in this aim, I was interested in seeing whether that lack of access affects uptake of an adult vaccination, and I specifically used shingles as a case example. So, like I just said, I wanted to evaluate the relationship between pharmacy desert status and shingles vaccination receipt. But to answer this question, I needed to get some data on local level data on vaccinations. And to do this, I worked with the departments of health of 7 participating states, which are outlined on this map here. And that was Washington, Nevada, Colorado, Oklahoma, Louisiana, Wisconsin, and Massachusetts. And this was a convenient sample of states. I essentially contacted all states that had information available on their websites about research, and these were the ones who were able to get me data that would work for this analysis. But these states are distributed geographically throughout the country and have a variety of social and demographic characteristics. So we deemed it to be suitable for this analysis. And what I'm looking at here, are the data that I asked for from these participating states was all adults aged 50 and older per the ACIP recommendation who got their second dose of Shingrix. So they became fully immunized in a 1-year period in 2022. And so I was able to geocode or just get the aggregated count depending on the state of how many of these adults were in each census tract. And in this way, I was able to approximate a vaccination rate at the neighborhood census tract level for shingles vaccinations. I then combined that vaccination data with the data set I just described for AIM-1, such that each row is a census tract in these 7 states. And for each census tract, I have shingles vaccination rate or an approximate shingles vaccination rate. I'll get to some of those limitations later. And along with the pharmacy access status and sociodemographic data that I described in the first study. So my hypothesis again was that the rate of adults age 50 years or older with shingles vaccination would be lower in census tracts that are pharmacy deserts compared to tracts that are not pharmacy deserts. But a key challenge in evaluating this hypothesis is residential selection bias, or in other words, people aren't randomly assigned to the neighborhoods they live in. There are a number of factors associated with that. And some of these factors might also be associated with whether they get a shingles vaccination. So to address this concern, I chose to use propensity score matching. And I'll only go over the methods at a high level for the purposes of this seminar, but I'm happy to talk more about it in the questions and answers section. But at a high level, essentially, with propensity score matching, I create 2 groups artificially in my data set that are balanced with respect to the exposure. So essentially, I'm going to take tracts that are pharmacy deserts and tracts that are non-deserts and create a balancing score for each tract based on the other characteristics of that tract that I believe are confounders. And I'll then match each pharmacy desert tract with a non-desert tract for tracts that have similar balancing scores. And in this way, it helps address confounding for a long list of confounders in a more efficient way than logistic regression can. So I'm going to do that for my main analysis. And then for my secondary analysis, I'm going to do that exact same thing, but instead I'm going to use this low access definition only. So only that first half of the pharmacy desert definition as my exposure. And this will allow me to evaluate if the relationship between neighborhood pharmacy access and vaccination changes, and potentially shed light on if that low income half of the definition is important. So the universe for my data set here is 9,652 census tracts across those 7 states. That's all those census tracts. And of those, about 6.7% were pharmacy deserts, and the remainder were non-pharmacy deserts. And I just did a quick unadjusted check before doing the propensity score statistics that just to check if vaccination rate differed between the two. And the unadjusted rate is lower in pharmacy desert tracts. So according to my hypothesis, that's what I expected. But what I wanted to understand is whether once you take into account possible residential selection bias or confounding, if that relationship still holds true. So I balanced my two groups with respect to a number of factors that are known to be associated with shingles vaccination. And this includes older age, marital status, gender, race, ethnicity, poverty status, healthcare use, education and health literacy, and even political party. So I created two balanced groups with respect to that. And take my time. In the interest of time, I'm going to go through this a little quickly, but what I'm looking for here is that there are members of each of my two groups, pharmacy desert tracts and non-pharmacy desert tracts, that have scores across the full range. So the height of the bars doesn't matter, but the distribution across the range of scores matters, because in this way I can match tracts with similar scores. And this diagram here shows in the orange dots the characteristic or the difference between the two tracts after balancing, which this dotted line indicates that all of the orange dots are within my acceptable level of difference after I've done the balancing, because the gray dots are the differences before balancing. So again, happy to talk more about this in the Q&A, but ultimately the summary of this slide is that I was able to balance nearly all of the census tracts in my sample to then evaluate my question. So I take my matched data set. My outcome was shingles vaccinations per 1,000 population, age 50 or older, and my exposure was pharmacy desert tract. I balanced them adequately and conducted my model, and I found that my results were not significant. It was a negative effect, which is the direction that my hypothesis was in, but the p-value was 0.83, meaning the results were not significant. But I then continued on to my secondary analysis, looking at low access tracts, and did essentially the exact same thing. Balanced my groups, checked that each group could have, it was possible for each group to be matched, balanced them, checked that the two groups were now adequately balanced based on my predetermined acceptable threshold for the difference between the two groups for each criteria. And I was able to match nearly all of these tracts as well. And ultimately, again, did the exact same analysis. My outcome was shingles vaccinations. My exposure was this time low access tract, so tracts meeting just that first half of the pharmacy desert definition. And this time I did find a significant difference between the two groups, in that the effect of a tract being low pharmacy access is 2.4 fewer shingles vaccination per 1,000 population. And this was statistically significant. Before getting into the discussion, a few strengths and limitations to keep in mind. A few strengths is that this is one of very few studies to look at the effects of pharmacy access on real-world provision of vaccinations or other pharmacy services, because this local level data was really hard to get. It took me over a year of going back and forth with a number of states to even get these 7. But this local level data is crucial for understanding neighborhood level effects. But there are a number of limitations. For example, in many state immunization information systems, reporting is not mandatory, especially for shingles. And there are little idiosyncrasies that add up, such as people having incorrect addresses or moving and not updating their address, etc. And I only had 7 states, and within those 7 states, only 7% of them were pharmacy desert tracts, and that impacted the power of my study to detect statistically significant differences that were small in magnitude. There are also a few other limitations with our denominator being an approximation, and it's very possible that I'm not including other important confounders because I only look at population level variables, not individual level ones. And we know that one of the most influential factors determining whether someone gets a vaccination is whether their primary care provider recommends them to get that vaccination. And I don't have insight into that at this neighborhood level data set that I'm using. And my data also looked at vaccine completions, but not timeliness. So it's very possible that being further from a pharmacy perhaps delays a person's timely vaccination, or whether they're delayed getting their first dose or have a longer delay in between doses. My data do not provide me insight into that either. That being said, there's a few takeaways that we can make based on these data. While there was no significant difference in vaccination completions between tracts that were pharmacy deserts versus non, we did find lower vaccination rates in tracts that had low geographic access to pharmacies in general. And if you multiply this difference out, it's a hypothetical deficit of 36,000 vaccinations that were missed because of the association with having low access to pharmacies. There's a few policy implications for this, but essentially it adds to the evidence base that poor geographic access to healthcare has real consequences for patient health. And in the first study, or in the first chapter of this, I mentioned several policies at the state and federal levels that might alleviate pressures on, i.e. ultimately prevent closures of pharmacies, that both state and federal governments should consider strongly. But certainly a lot more research is needed in this area. I mentioned many important limitations of this study that future studies would add a lot of value in addressing, including timeliness of vaccinations and granularity of access radii, because one of the findings of this from a research perspective is that the income component of that pharmacy desert definition may not add a useful amount of precision in identifying communities that have gaps in access to pharmacy-based services. Okay, our last knowledge check. Which of the following is not true of the pharmacist's role as a vaccinator on the patient care team? Which one is not true? You can drop it in the chat again. Okay. I'm seeing a lot of answers of C, that the role of the pharmacist as an immunizer is becoming less important over time. And that is correct. The role of the pharmacist as an immunizer has been becoming more important over time. In the past decade, both scope of practice for pharmacists and the number of vaccinations recommended has been increasing, and pharmacists are expected to take on more and more of patient interactions with regards to vaccinations. And research is showing that pharmacists are really key allies on the patient care team as immunizers. Okay, tying it all together, quick time check. Okay, in conclusion, pharmacies, as we knew, are important access points for healthcare and on average are widely distributed. Although nationally, there is important heterogeneity in pharmacy access and that millions of people don't have easy access to one. And we quantified this in part one, what I just reviewed, which showed about 16 million people don't have good access to a pharmacy. Our first study also confirmed that these pharmacy desert neighborhoods are distributed throughout the country in every state, urban and rural areas, and people in these neighborhoods differ systematically from those that do not live in these neighborhoods. And so though its operational definition is still developing, pharmacy access has many implications for patient and population health, which we examined in part two. And one of these implications is differential access to pharmacy-based health services. And in part two, we found that the rate of shingles vaccination receipt might be lower among people living in neighborhoods with low access to pharmacies. So more research is needed on shingles and other pharmacy-based services to understand and ultimately address gaps in patient access to these vital services. And I'd like to thank my dissertation committee for this research. Was fundamental in my learning throughout this process. Dr. Andy Sturgachis, Dr. Jennifer Bocci, Dr. Parth Shah, and Dr. Steve Mooney. And I saw Parth was on the call today, so thanks, Parth. And I'd also like to thank all of my collaborators and funders and mentors at University of Washington and beyond. without whom this research would not be possible. So I'll stop sharing there because I'd love to have some discussion. And thank you all for listening during your lunch hour here. I really appreciate it. So I look forward to your questions. Thanks. And feel free to either drop some in the chat or unmute yourself. Or if I know there's folks in person in the room, so Sydney, if you wouldn't mind relaying any in-person questions, that'd be great too.
Hi, thank you very much for your presentation. I'm in the classroom. Sorry, I'm using a mic in here. My name is Emily. I'm a PharmD PhD student. This was a really interesting talk. I loved your map of the US and just kind of putting everything in the hot spots and seeing those pharmacy deserts. And my thought there was mobile pharmacies. And curious about your thoughts on sort of the potential for other alternatives to brick and mortar community pharmacies where we can input pharmacists like the mobile clinics and the mobile pharmacies, how big of a role that could be. Yeah.
Yeah, great question and very forward thinking. I love it. Just to restate, so yes, the current map that I showed doesn't include innovations like that, or I'm only looking at brick and mortar pharmacies here, that because that's what the NCPDP data set has. So what I don't include are things like mail order pharmacies, and you mentioned mobile clinics or one-off uh, vaccination drives or other service drives. So that's definitely also a limitation of this work. And looking ahead, things like mobile clinics can be good, but I think if they're used in a targeted way, then it can certainly fill certain gaps. But overall, having patient access to regular contact with the pharmacist in person is an important part of managing many medication regimens. For example, mail order pharmacies can open a lot of doors in terms of people being able to regularly access their medications if they can't travel to a pharmacy. But it also removes that face-to-face interaction with the pharmacist who may be able to answer questions or provide services like vaccinations that can only be done in person. And so I think mobile clinics can face some of those same challenges if they're roaming around and can fill gaps in a more of a acute sense, but not a ongoing chronic way. But I think it can be a great band-aid measure while some of the long-term access questions to these services are evaluated. So yeah, that's my reaction. But it's a really interesting thought, and there's so much innovation happening in this space that I'm excited to see where some of these mobile clinics end up.
Thank you. I'm excited too.
Great. I see a question in the chat here from William. Do you think your findings on the shingles vaccine would be similar to the HPV vaccine? It's a great question. And I'm actually in the process of learning more about the HPV vaccine myself. That's what I'll be studying more during my postdoc starting next month. But there's some pretty big differences between the two. Many pharmacists in all 50 states are allowed to administer shingles vaccines and in many cases prescribe them as well. And that is not the case with an adolescent vaccine like an HPV vaccine. So in they're pretty different vaccines, but in theory, if pharmacists were allowed to prescribe and administer HPV vaccines, I might expect a similar pattern. Although teens are still, or adolescents who are the target group for HPV vaccines are still going to their primary care provider and may get their HPV vaccine from the primary care provider instead, in a way that's quite different from a shingles vaccine, which are almost all delivered in pharmacies. And that's partly due to a legacy of shingles being part of Medicare Part D when it used to be Zostavax, which was recommended for 60 and older. And so we're primarily on the Part D benefit plan. And that's part of the reason why they're mostly delivered in pharmacies right now. So I would expect there to be possibly a smaller effect for HPV vaccines right now, but in the future, the scope of practice for pharmacists in this area is changing. So maybe we would see a bigger effect. Thanks. Another question from Ilan. Why did you choose 2 to 1 and 3 to 1? Great question. And that is actually just an error on my part. I was updating my slides and forgot to update that one. I had initially been using a 3 to 1 matching, but then was getting a better matching ratio when I switched to a 2 to 1. So both parts did a 2 to 1 matching ratio. So that's just an error on my slide. So thank you for catching that. My apologies for the confusion. Okay. Question from Cindy, or I'll pause for a sec if there's any other live questions. Otherwise, I'll go on to another chat question.
I saw Starlin pop on. I don't know if she has a question.
I do. This has to do with so the CDC has invested wisely in increasing embedding pharmacists into prevention of diabetes, stroke, blood pressure, asthma for self-management programs. What I have experienced in my state, in Illinois, which has a great many pharmacy deserts, is that the metric that they're measuring success of this is by brick and mortar pharmacies. We have experienced the fact that 15,000 students are graduated every year, and we actually have a better workforce of advanced clinical pharmacists that could go into these areas, not permanently be based at the brick and mortar pharmacy, but enhance that service area in these needs with immunization, with diabetes, and also using some technology to do that. I am very excited about your work. I have been trying to meet with CDC and CMS and address the bricks and mortars are going away, but we have a vast community of advanced care pharmacists that could fill in those gaps. I just want to hear your opinion, and I want to use your paper at the next CMS call that we have.
Oh, please do. That's awesome. I'm glad to hear it could be useful. And I'm happy to email you the link directly. And because in our paper and in the supplemental materials, there's this interactive maps. You can even zoom in on your state for specific examples of pharmacies. And all of our R code is open access. So if you have anyone on your team who wants to do ad hoc things, you are very welcome to do so. But yeah, I think that sounds like a fantastic initiative because, like you said, the closure of brick and mortar pharmacies is a huge challenge. And so anything that can be done to bolster existing ones and improve patient access to these services. We know there's provider shortages for primary care, for pharmacy, for so many professions right now. So the more that these care models can be explored to improve outcomes for patients, I think is fantastic. So I'll be happy to email you that. If you can you put your email in the chat. Perfect. You're one step ahead. Thank you for the question. Let me write this down. Okay. And Cindy, you're asking about what about the COVID vaccine or flu and pneumonia? Similar to the HPV vaccine, every vaccine is just so different and has its own challenges. But pharmacists are, like I said, administering many of the COVID vaccines and flu and PCV as well. So I think the more access that patients have to pharmacies and more location options, whether a patient prefers a primary care provider or a pharmacist, I think is a good thing. And in areas where there are fewer options to receive these vaccines, I think we would expect to see a negative impact on uptake of these vaccines. So whether or not it's as big of an effect with shingles vaccine as compared to the shingles vaccines, it's hard to say, especially as COVID vaccines are yet to really be in a seasonal pattern. We're sort of coalescing around fall boosters, but it is yet to really solidify in the same way that flu does. And flu is still commonly provided by primary care providers as compared to shingles. So again, I might expect there to be a slightly smaller effect for these other vaccines, but ultimately I think the more options that patients have to get these vaccines in ways that are convenient and acceptable to them is a great thing. I see, Lauren, you just unmuted. Yeah, do you have a question?
Yes. Hi, I'm with the Illinois Pharmacists Association. I work along with Starlin. I have a question. So, in my head, thinking about this and access to care, the COVID-19 pandemic, there was a huge surge in vaccination when that came out. Do you think that data was shown um, in your research, I would say? Because how I'm thinking of is, yes, we are improving access to care, and then COVID just kind of spiked and put pharmacy on this huge platform, and now we're like, okay, we're immunizing everyone, and now states can immunize for more than COVID and do childhood vaccines. Like Illinois, we can vaccinate 7-year-olds. And so I guess my question is, have you seen like a trend or like a difference in the scope of your timeline or like in other timelines that you've seen?
Yeah, great question. I think there's a few things there. So when I was looking at getting just my shingles vaccination data, many states were able to offer me vaccination data for 2019, 2020, 2021, and 2022. So I was able to look at all 4 years. And CDC has also now made their vaccination data available across that timeline, pre and post COVID. And there was a drop in shingles and flu vaccines during this time, but it wasn't as big as I would have expected. So pharmacists were still able to vaccinate through that time. I think pharmacists being able to immunize for children's vaccinations is still pretty new. And there are some interesting studies coming out, including one by my committee member, Jennifer Bocci and Parth Shah, who is still on here, looking at the relationship between whether children are receiving their vaccines in a pharmacy and whether that impacts how often they have well child visits, because that's been a concern from primary care physicians who are part of the care team in this regard. And their study actually found that children were not more likely to miss their well child visits if they received their childhood immunizations from a pharmacy. So I was not involved in that study, so I forget the exact details, but I think that's coming out soon, and it would be interesting to check out. You also asked about volume of services in pharmacies, and I think you're totally right. I think COVID really put pharmacies at the forefront of people's minds for being really important care locations, not just for picking up your prescription in the back of a CVS or something, but that pharmacists are really vital healthcare infrastructure. So I think the whole pharmacy and public health community is looking at pharmacies as great footholds in a community for well-trusted providers who can provide a number of services. And I just gut reaction would expect the role of the pharmacist to continue to grow in this way, but I think it's still a little early to tell whether there's been a huge explosion in number of vaccines that pharmacists are providing. I think there's still a little bit of catch up going on with vaccines that were missed during COVID.